And I think that we'll move because I see that our next speaker is ready to join, and it's Larissa Waldman, and she is going to talk to us today. Welcome. This is our first opportunity to meet, so thank you so much for giving your time and your expertise on this. You are going to be talking about a very hot topic in kidney cancer. And we're just going to today ease into it with a genetics and genomics 101. We get constant questions about this topic. And so I think that you might enlighten us a little bit, give us the basics, help us understand a little better. And we really appreciate you coming to join us today. So I'll let you take it away. Thank you.
Thank you very much, Christine. One moment, I will just share my slides.
Yep. And I should just let people know that you are attached to the Sunnybrook Health Services in Toronto, and that you're a genetic counselor. And we really appreciate you being here. Thank you.
Thank you so much. And thank you, Christine, for inviting me today. As you just mentioned, I'm a genetic counselor at the Sunnybrook Odette Cancer Center in Toronto. I wanted to start off by giving a little bit of an introduction to genetic counseling, and then we will discuss genetics and genomics. And I'm very happy to take any questions as they come up today. I do have a disclosure. I've received honoraria from Merck in the past. As an overview of this presentation, we will talk about genomics and genetics. I also want to touch on hereditary and sporadic cancer, as well as genetic testing criteria for hereditary renal cancer. We will talk about how you can access genetic testing. I know we have participants from all over Canada, and access may look different depending on where you live, but hopefully we can address where you can access that testing. And then I would like to talk a little bit about additional genetic testing considerations, including how to understand your genetic test report and the Genetic Non-Discrimination Act. To begin, I would like to introduce what a genetic counselor is. We are not a very common profession yet. We are often based in tertiary hospitals, and so we don't get to meet everyone who should really be accessing genetic testing. But genetic counselors are healthcare professionals who have advanced training and experience in medical genetics and counseling. We often work as part of a healthcare team, and we see people who have personal or family histories of specific health conditions. So in my practice, I work at the Odette Cancer Center at Sunnybrook. I see people who have a personal or family history of cancer. And we hope that the information we provide to patients allows you to feel empowered in making decisions regarding your own care, your own management if you currently have cancer, screening for any cancers you may be at risk for, as well as informing family members and family planning. Just to set the stage, I did want to go over some background of genetics and genomics. So our bodies are made up of trillions of cells, and inside each of our cells, we have structures called chromosomes, like you see here. And our chromosomes hold on to our genetic information. Now, if we were to unwind a chromosome, as you see in this diagram, we would see long stretches of DNA. Now, genes are portions of the DNA that are the instruction manual for how our bodies grow and develop. The genome, though, is all of the genetic material, all of the DNA that's found in a cell. While some of that DNA codes for genes and codes for proteins, other stretches of DNA are non-coding. They do other functions, including regulating which genes are turned on and turned off in specific cells. So when we talk about genetic testing, usually we are referring to testing specific genes. When we think of all of our genetic material, all of our DNA, only about 2% is actually genes. The rest serves other functions. Now, there are tests that look at the whole genome. But for the most part, our understanding of genetics is limited to coding genes. Now, when we think about genes, we typically have 2 copies of every gene. We can inherit mutations in any of our genes, and mutations, which are also called pathogenic variants, cause that gene to stop working properly. Mutations can also be caused by errors in cell division or environmental factors like radiation or smoking. Now, as I mentioned, mutations are also known as pathogenic variants, and we'll come back to this in a little bit when we talk about interpreting your genetic test report. When we think about inheriting a gene mutation, we can consider the genetic information of our parents. So in this diagram here, we see the mother has 2 working copies of a specific gene. The father here has 1 copy that works fine and 1 copy that has a mutation. So if they were to have children, in each pregnancy, the mother would have a 50% chance to pass on the copy of the gene that we see on the left and a 50% chance to pass on the copy of the gene that we see on the right here. The same for the father depicted in this diagram. In each pregnancy, there would be a 50% chance that he would pass on the copy of the gene that works fine and a 50% chance to pass on the copy with the mutation. When we think about cancer, it's helpful to take a step back and think about cells that typically work as we expect. So generally, our cells grow and divide in a very regulated way. We all have about 20,000 genes, and a subset of those genes, their job is to regulate how quickly our cells grow and divide. Now, sometimes we have a mutation in one of those genes that typically prevents us from developing cancer. And when we have a mutation in one of those genes, it causes us to lose some of that protection, and it can lead to cells dividing in an uncontrolled way and tumors or cancer developing. If we think about all cases of cancer, we know that only a small proportion are due to an identifiable genetic mutation, and we call that hereditary cancer. And so these are cancers that we can see grouping together on the same side of the family. We test someone who has that suspicious cancer and we find a mutation. That's about 5 to 10% of all cases of cancer. Another 10 to 20% are what we consider to be familial cancer. That's when we see similar types of cancer grouping together on the same side of the family, but we can't identify a specific genetic mutation. And that could be because there are smaller genetic factors that might build on each other and can lead to the development of cancer, but it's not something we can test for yet. It can also be due to having a shared environment. So families generally might live in similar areas and can be exposed to other environmental risks. And so we know that about 10 to 20% of all cases of cancer are what we consider to be familial. The other 70 to 80% are sporadic cancers, meaning that they can be caused by factors we can't quite pinpoint yet. It could be environmental, lifestyle, aging, again, factors we don't fully understand yet. When we think about renal cancer specifically, we see a similar proportion of hereditary cancer, so about 5 to 8% is due to an identifiable genetic mutation. A larger proportion, about 38%, are familial. Now, I expect that at this point in time, we might not have identified all of the genes that are associated with a higher risk to develop renal cancer. I think that our testing is still a little bit limited, and hopefully over time we will identify other genes, and maybe the proportion of that familial group might actually end up being able to be identified through a genetic test. And then about 60% are sporadic. When we think about who should be referred for genetic testing or who should be thought of as potentially having a hereditary renal cancer syndrome, there are different publications out there that we can reference. Many professional organizations have come together to identify who is at highest risk to have a hereditary renal cancer syndrome. That includes the publication you see here at the top from the American College of Medical Genetics and Genomics and the National Society of Genetic Counselors. They came together and created criteria for referrals for a variety of different hereditary cancer syndromes, including renal cancer. And the publication you see here at the bottom from 2021 is a consensus statements from a group of urologists, medical oncologists, geneticists, and genetic counselors in terms of who should be referred for assessment in genetics. I'm including different criteria here on the slide. The reason I'm doing this, I'll talk about Ontario specifically in a moment, but I can appreciate that many of you may be outside of Ontario. And your center may be using criteria that are published from different sources. One of those sources that's commonly used is called the National Comprehensive Cancer Network, or the NCCN. Their most recent version of criteria are listed here. Another common criteria often referenced are the Canadian guidelines published in 2013 from the CUAJ. I do want to reassure you that whatever criteria your center is using, that they're very similar. There might be some very slight differences, including 45 years of age versus 46 years of age. But overall, these criteria are very similar. They include bilateral tumors, so tumors on both kidneys, or multifocal tumors, so tumors in different parts of the kidney. Close relatives, so first or second degree relatives with renal cancer. And then different features of syndromes that have been associated with kidney cancer. For example, pneumothorax, which is a collapsed lung, which has been associated with that hereditary renal cancer, at least in conjunction with certain gene mutations. The Ontario criteria are also very similar to those I just displayed on the screen. For those who have a renal cancer, you can have genetic testing. You meet criteria if it is bilateral or multifocal, if it's been diagnosed at the age of 45 or under 45, if you have a family history of a close relative, so a first or second degree family member who has a renal tumor, if the pathology of that cancer is not clear cell, so some of those are listed here, that information is usually available to your urologist, to your medical oncologist, to genetic counselors. If there is evidence of having one of those syndromes, so not just having renal cancer, but having some of the other features that we do see in these syndromes, and having a personal or family history of other associated tumors. So by meeting any one of these criteria, you can certainly be referred to a genetics clinic for consideration of genetic testing. In Ontario, at minimum, when we organize testing for people who have renal cancer, we would test at minimum the 15 genes you see listed on your slide. Now, depending on the family history, we may add on additional genes. And if you are seen at a different center, these are generally the genes you would be tested for at minimum. I wanted to include this study that you see on your screen because unfortunately we are still at a time in the space of hereditary renal cancer where many patients do need to be self-advocates for consideration of genetic testing. We are still learning as the healthcare community on how we can best make sure that patients access genetic testing. But we do certainly appreciate when anyone comes to see their oncologist or their urologist and says, I understand that I meet genetic testing criteria. Would you mind referring me to a genetic counselor? And we would be happy to see you to assess your eligibility for genetic testing. The study you see here was published about 4 years ago, and it looked at a population database and applied the Canadian criteria for hereditary renal cancer. And found that about 35% of patients were identified to be at risk, so meeting those criteria for hereditary renal cell cancer. Now, these patients were never actually tested, so we don't know the proportion of that population who truly do have a mutation, but we do know that not all of these 35% were offered genetic testing or were referred to a genetic counseling clinic. And so there is a gap in care in terms of knowledge or barriers and access to testing. Because of this, I would like to talk about how you may be able to access genetic testing for renal cancer. One of those is a very standard process. It involves getting a referral to a genetic counseling clinic from your doctor. That could be your urologist, your medical oncologist, your family doctor. Typically, once a genetics clinic receives that referral, we would often send a family history questionnaire to you to complete to make sure that we are testing for everything we should be in the family. Once that family history questionnaire is returned back to us, we then book you to see us, we meet with you, we talk about testing, then we send off for genetic testing, which is usually done through a blood draw or a saliva sample. And usually the turnaround time for those results is about 2 to 3 months. Once those results are available, we tell you about them and we organize any follow-up as needed. Unfortunately, because of wait lists in certainly in the province, but also in most of Canada for genetic counseling clinics, they're quite long. And so there is a lengthy wait to get to be seen and to access that testing. And because of this, other models of care have been considered. One of those is what we call the mainstreaming model or point of care genetic testing. This is increasingly becoming available in cancer centers, including at Sunnybrook. I know in other cancer centers in Ontario and British Columbia. Increasingly, this is being seen as a good way for patients currently undergoing treatment to access testing. This involves your urologist or medical oncologist identifying that one of their patients meets criteria for genetic testing and offers it to them on the day of the visit. On that same day, they go for that blood draw. So instead of having that whole waiting time where we get that family history questionnaire started and we wait to meet with you for that pre-test appointment, all of that is done in a shorter conversation with your oncology team. As we wait those couple of months for your results, that's when a family history questionnaire may be sent. And that really does shorten that time frame for us to get those results back to you. At the same time that blood is drawn, oftentimes a referral is sent to the genetic counseling clinic so that we can keep our eye out for your result. And if it is positive, we will be following up with you to arrange any follow-up care. At Sunnybrook, patients may see a poster that looks like this just in the hallways, trying to provide information about who is eligible, like we discussed, so that they can bring it up with their oncology team. And we often have barcodes on those posters that link to videos that provide more information about genetic testing. Again, mainstreaming genetic testing, this point of care genetic testing, is an increasingly used model in cancer centers. It is worthwhile asking your healthcare team if you meet the criteria for genetic testing under that model. If you don't meet that criteria for that mainstreaming, you can always ask if you can be referred to a genetic counseling clinic. Maybe there's other cancers in your family that should be investigated, even if it's not directly related to the kidney cancer that we see. In terms of results from genetic testing, I would like to talk a little bit about the variants we may find and what that means when you see it listed on your report. So when we think back to those 15 genes that we commonly organize, that's all done through the exact same blood sample or saliva sample. Now, when that report comes back to us, it will either include listed variants or it'll be negative. The type of testing that we organize is called sequencing. And sequencing means reading the letters of those genes, letter by letter, looking for any spelling mistakes or mutations that cause those genes not to work properly. Now, if a variant is found, it's not automatically considered to be a mutation. There's actually very strict criteria and a very high level of evidence that is needed to classify that variant as a true pathogenic variant or a true mutation. There's also a very high level of evidence that is needed to classify that variant as benign, as one of those genetic changes that doesn't impact our health, that doesn't impact the functioning of that gene. Maybe it's just one of those genetic changes that make us different from one another, but doesn't impact our risk for cancer. And so there is a list of standardized criteria that labs do need to follow when they identify a variant. Now, if that variant meets 99% of those criteria and it is classified as pathogenic, if it meets 90%, it is likely pathogenic, meaning that we're fairly certain that is a true mutation, but it just doesn't meet that 99% yet. If it meets 90% of the way to benign, then it's likely benign. If it's 99%, it is classified as benign. There is this middle category that you see here that we call a variant of uncertain significance, or a VUS. What that means is that when they identified that genetic variant, as the lab was looking into it, they found either that there is conflicting evidence. So some evidence points towards benign, some evidence points towards pathogenic. And because of that conflict at this time, we can't resolve it, and it's a variant of uncertain significance. Or it means that our level of evidence just isn't there to put it in either one of these categories. Maybe this is a variant that we have very rarely seen before, and so we just don't have enough information yet. When we think about a report, a pathogenic or likely pathogenic variant is considered to be a positive result. They're both considered to be mutations. And the only variants that tend to show up on reports are pathogenic, likely pathogenic, and VUS results. The reason for that is because likely benign and benign results don't impact our health, don't impact our healthcare management, and we all have so many of these benign variants that it would result in very lengthy reports. So these are the types of results you would commonly see. For pathogenic or likely pathogenic variants, that would lead to a discussion about how your care would be changed or managed based off of that variant. In the context of a variant of uncertain significance, most of the time, we wouldn't recommend any changes to your own care. We wouldn't recommend testing of this variant to family members because at this time, we don't know what it means. But oftentimes you'll hear your genetic counselor say, we want you to come back to us in a couple of years to check in on the status of that variant. Maybe over time, we'll be able to resolve what it means. I included here on the slide some reasons why people may decide to pursue genetic testing. it's not the right decision for everyone. And as Dr. McAlpine was saying, it's important to take into consideration every patient's personal decisions about proceeding with any type of management, including genetic testing. Some patients decide to go ahead with testing to see if there is a genetic explanation for their personal or family history. Sometimes that provides some sense of closure. It can provide surveillance for other at-risk tumors. So some of the genes we test for can indicate an increased risk for other tumors or cancer that might not be on our radar given that person's personal or family history. It can give us information about any targeted therapies. I know belzutifan was discussed earlier. That is one example. It can guide surgical planning. It can also guide family screening. So as we talked about earlier, identifying a mutation in one person tells us about the risk of other family members having that mutation. And we would want to make sure that those family members are offered testing at the appropriate time, at the appropriate ages, and for those who test positive, that they are screened for those at-risk tumors. And for family members who may be building their own families and having children, this could provide information that they may use for preconception or prenatal testing. I finally just did want to touch on the Genetic Non-Discrimination Act, or GNA. The reason I'm bringing this up is it is often a question we get in clinic. This is a law that was passed in 2017 that aims to protect patients from the use of genetic test results in certain settings. Those include insurance and employers. And so the aim of this law is to try and prevent some insurers or employers using genetic test results to make decisions that could impact premiums or employment. What this means on a more practical basis, I understand that many life insurance providers now have a clear statement on the forms that ask applicants not to disclose any genetic test results, as they can't be used when determining premiums. That being said, it does not prevent insurers from using information about a personal history of cancer or a family history of cancer. This law was really aimed to provide some reassurance to patients who otherwise may have declined proceeding with genetic testing based on worries around discrimination. So with that, I would like to, first of all, thank all of you for attending. I'd like to thank my team at Sunnybrook, and I would like to open this up to any questions you may have. Thank you.
Thank you so much, Larissa, for joining us today and giving us this great informational presentation. I learned a lot. And now I am questioning whether genetic testing might be right for me, not probably to the level that it is as important for some of our other patients. And I hope those that are joining us today also gain some insight whether this is the right thing for them to investigate. That was one of my questions. Are you automatically referred by your urologist, or is this something that patients need to advocate for themselves?
That's a very good question. I think it is something we encourage patients to advocate for. We are doing our best to provide education to our colleagues across all healthcare disciplines, from urologists, medical oncologists, GU nurses. That being said, it is fairly new in terms of how this can be applied to cancer care. And so it was not often part of practice or training. And so
Right.
we are certainly doing our best to provide that education. But I think for the most part, we do recommend that patients advocate for this as well. And we see that so often, and not just for kidney cancer, but from everything from breast, ovarian, colon. Oftentimes it is the patient themselves going to their healthcare provider, whether that be their healthcare provider in their cancer setting or just their family doctor, and saying, look,
Oh,
I
okay.
have this suspicious history. I wonder, could this be genetic? Could you refer me to a genetic counselor? And oftentimes that's how we see patients in our clinic.
So that is possible. Go back to your family doctor and tell them your
Yeah.
concerns, and then maybe they can arrange it for you. At this time, I'd like to invite our patient rep, Christine Golding. Oh, sorry, I keep doing that. Christine, please join us. I know that we're so appreciative of you joining us today, and you have some insight as well. So, Christine, maybe you could share just a little bit of your experience with genetic testing, and maybe you have a question or two for Larissa after that presentation.
Yeah, for sure. First, I'd like to say thank you to Larissa. There was a lot of really good information in there. Some of the stuff as she was talking, I was kind of thinking about my experience, and so it really made me think as well, like what some things I might consider in the future would be. So definitely. Okay, so I'm Christine, and I'm a kidney cancer patient. I was first diagnosed in 2020, August of 2020. Just after some health issues and some weight loss and a whole bunch of other things, they had sent me for just a generalized CT, and of course that's what popped up for me. And so at the time of my diagnosis, I was 41, I guess I would have been. And so my uro-oncologist had recommended that I get the genetic testing. And unfortunately, in Manitoba, it's actually 40 is the cutoff. So he had to really advocate for me to get the referral to the genetic counselor. So it was kind of interesting to hear that, like, that 45, 46 is the standard, because he really had to work hard to get me through to the genetic counselor. My experience was very similar to most people who were dealing with anything during COVID. Everything was done over the phone. It really did not, I didn't get the sense that it was like the full normal experience. I didn't meet with the genetic counselor until the final stage with, like, when the results, so they had sent me for all the testing prior to, and then it was only once the results had come in that I finally actually talked to somebody from the genetic counseling. My history that they had, they didn't take a full history for me either. They just used what was in my file from my uro-oncologist. So there was a little bit missing. And when I had that conversation at the end with the genetic counselor, a few more things had sort of popped out as flags, and they had said, oh, well, that might have changed the way we did the testing. But then it wasn't done in the end anyways. Like, we just kind of left it at that. So wherever my genetic testing was at that point, it was left there. My genetic testing came back in the negative range. I had a couple of mutations which they didn't think really meant anything. So I guess in that middle range that Larissa was just talking about, but nothing that was already known. So that was that piece of it. So yeah, that was my whirlwind history with the genetic testing. I chose to do the genetic testing not for myself personally or for my care. I actually chose to do genetic testing for my 3 children, just because I wanted to kind of keep that thought in mind for them, and if they wanted to pursue avenues. If something did pop up, then at least they had some more information available to them. One of my children is already an adult, and so she asked that I not reveal the genetic testing to her. She does not want to know in either direction. My two younger children, I don't think they understand enough to know what it means at this point, so we just kind of left it. So none of them really know the results of it, and those are conversations I'll have with them if they feel they want that information or not moving forward. So that's what I use that genetic testing for.
That's very interesting, Christine, when you share that. Do you now feel, and Larissa, maybe you can help us out, she kind of felt at the end it wasn't completed to the point where it should have been. Is it too late for her to go back now and say, listen, I think there's some other things that have popped up, or maybe it wasn't, can we do it again? Is that possible?
Yes. Oh, first of all, Christine, thank you so much for sharing your experience. It is absolutely possible, and not just possible, but recommended, that anyone who has had genetic testing, regardless of your results, negative, uncertain, positive, you continue to have a relationship with your genetics clinic. The reason for that is because our testing changes over time. In fact, genetic testing is really on this trend. It changes very, very quickly. And it could be that criteria changes, meaning that you're now eligible for a broader subset of genes, or B, our technology gets better, the number of genes we test for increases, or just the sequencing platform itself gets more accurate. And so generally, Christine, it's tough for me to talk to your case.
Yeah, I know we're both.
But generally, the recommendation is that if your result is negative or it is uncertain, you follow up with your genetics clinic every 2 to 3 years. And that could just be saying, giving them a call and saying, hi, nothing has changed for me personally. Nothing has changed in my family history. I just want to check in with you and see if anything has changed in terms of the testing you have available. Or it's an opportunity for you to say, look, I've had these new cancer diagnoses in my family. My care hasn't changed, but because of these other cancers in the family, is there anything else we should be testing for in me? And that would either involve the genetics clinic saying, look, we would just need a new referral from you just to get you back into our system. But we have all the history we had before. We need you to do a new blood draw or a new saliva sample, or maybe they'll even say, you know what, the DNA lab that we used for your testing, they store DNA indefinitely. So yours is still banked. So we just need to send them a requisition. So absolutely continue to follow up with your genetics team.
You just brought up an excellent question that's been asked in the chat. How long do they hold the patient sample, and is it available for further testing later, or does it become non-viable?
It's a very good question. It is a little bit lab dependent. So there are some labs that might store a DNA sample for a year or 2 years. And then just because of space issues and resources, we'll need to discard it. Other labs keep those samples indefinitely. Sometimes it depends on a consent that you sign for your initial testing. So you may say, you know what, I give you permission to store this for 10 years, and then it should be discarded. It's really, really lab dependent. Sometimes though, even if a lab is storing your sample indefinitely, it still may be recommended that you have a new blood draw. And some of that is just going to depend on whether there's been such an advance in the technology that they use for sequencing that they just want to use a new blood sample anyway, just to keep everything as up to date as possible. So it's something you would need to speak with your genetic counselor about.
Okay. I have a couple of more questions, but Christine, did you have something that you specifically wanted to ask?
No, she actually kind of covered my thought process on how to go about and re-ask for like that referral, or is it, but I do have a little question. Is it easier to, and maybe this isn't, Larissa might not even know this, but is it easier to get a referral if you go through your uro-oncologist, or is it easier to get a referral from your family doctor? Like, does it matter? Is there priority based on your doctor?
At least at Sunnybrook, there's no priority based off of the doctor who is referring you. We do, however, sometimes prioritize patients based off of how it will impact their care. So, for example, if there was someone newly diagnosed and there's this suspicion of a hereditary renal cancer syndrome, and the team wants this result really quickly because it'll impact surgery, it might impact other planning for care, then we might try and get that person seen a little bit faster. But it doesn't matter if that referral itself for us is coming from their family doctor, from their med onc, from the uro onc, whoever it's coming from. It's really just depending on the referral.
Thank you. That's great. I have another quick question for familial, I'm not going to be able to pronounce that, familial or sporadic kidney cancer. Are ultrasounds recommended or CT scans for relatives, like especially those that might be overweight? Does that make a difference?
That's a very good question. So my recommendation, if you see kidney cancer in your family in multiple relatives, first of all, go speak with a genetic counselor, see if you meet any criteria for genetic testing. If you do, and if that testing is negative and you still see that history that's suspicious, then yes, you likely fall into that familial category. And the recommendations for screening will very much be dependent on that history and what is seen, and would be in conversation with your genetic counselor and your geneticist. So unfortunately, I can't speak more to that. It would be very much dependent on the family and on the patient's history.
Okay, and I have one more important question about the insurance company and access to that information. Are the results public? Is that what I understood?
No, that's a really good question. So results aren't made public. The testing that I've described, that's all clinical testing. That's something that you have access to, your genetic counselor has access to, your healthcare team has access to, but it is certainly not made public. That being said, what I was referring to was if you're applying for life insurance, or if you're having a discussion by the water cooler, if we're all working in person and you happen to say, I was found to have a mutation in XYZ gene, and your boss overhears, how could that impact you? And this law aims to say that shouldn't impact your employment, that shouldn't impact your insurance premiums. That's the aim of the law. And it was such a huge effort on really the part of different patient organizations. The Huntington disease patient advocacy groups were really involved in getting that law, in advocating for that law, as well as genetics teams. That being said, I am a genetic counselor, I'm not a lawyer, I'm not an insurance provider. So the nitty-gritty details of that law is not something I'm able to speak to. Also, to my knowledge, it hasn't really been tested in our court system yet. So I can't speak to the strength of the law.
Okay. So in other words, it's good to ask questions to protect yourself. And it's good to advocate for yourself for genetic testing to protect your family and yourself. I have one more quick question, then I'll let you go. Thank you so much. This has really been very informative and very effective. And we hope to have a full webinar on March, which is Kidney Awareness Month, on a little more detail of genetics and genomics. But we often get questions from our patients that, and this may not be your area, can I have genetic testing to tell me what is the right treatment for me? And some are tempted to go to the US because there is the offer of these great genetic tests. So is that viable? Like, is that something, or?
Yeah, I mean, it's really, tough for me to say. Overall, I would like to differentiate. There's what we call germline genetic testing, and there's somatic testing or tumor testing. Germline testing looks at the DNA that you inherited. Somatic testing looks at the DNA sequence of the tumor or the cancer. Now, we know what, as I mentioned in the presentation, what makes cancer grow and develop is it accumulates mutations that are not present in the DNA you inherited from parents. And so when we do testing of the tumor, we could find way more mutations than are present in the germline. Sometimes identifying those mutations does help to guide the selection of certain therapies. It's not really my area of expertise, and it's best to speak with your medical oncologist about that. But overall, those are just so you know, those are the different tests that are available if you're looking for those tests. There are some companies in the States that do somatic testing. There are hospitals in Canada who do somatic testing. There are places in Canada and the States that do germline testing. It's just best to be aware of what type of testing you're looking for.
That's very helpful because, it's very distinctive, and I don't think any of us really knew that, or I certainly didn't know that. I have one last question, and then I know I'm cutting into my next presenter's time after the break, but he's the one asking the question. So it's really quite interesting because, the new genetic test that you can send away for. How do you feel about these commercial tests? Is it going to give you any valuable information or not really?
That's a very good question. It is very much company and lab dependent. So there are direct-to-consumer genetic tests that are validated and reliable and test exactly the way we would test in our system. There are others, and I see here in the question specifically mentioning, for example, 23andMe, which we wouldn't use in the healthcare setting in terms of results. We would want to validate and do our own testing. Part of that is because they may not test for all the genes that we do. Part of that is the platforms they use. So we would consider tests like 23andMe or Ancestry to be more entertainment type of tests versus medical tests.
Thank you. That's valuable because there may be some that are misguided. Often the information is well presented and you think that you're getting more than what you really are. So thank you for that. I thank both Christine. Thank you for sharing your story and your experience and your question, because actually that's very valuable. People that have had genetic testing and it's been a little while, you may want to reinvestigate getting it done again. I think that might be very important. And you've really cleared up a lot of questions that I had between genetics and genomics and trying to understand it all, because it is complicated. But that's great information for our patient audience. So thank you for both of you for joining us today.
Thank you, Christine, and thanks again for everyone attending. Enjoy the rest of the day.